doctor 5 years ago, but he refused medical and surgical treatment at the time. He chose to seek alternative treatment and did not follow up with the urologist over those 5 years. Mr. Banda has now presented with anemia and hypoproteinemia. The several diagnostic tests that the hospital conducted indicated that the cancer had metastatized to his bones and spread locally to his lymph nodes, with the primary tumor invading his bladder and partially obstructing the left kidney. Mr. Banda had several admissions over a 2 month period for various reasons. The medical team told him on the last admission that only have 4 to 6 weeks to live. After a cystoscopy, after a cystoscopy showed further extensive growth and tumor of the tumor, and any further surgical medical intervention would not be appropriate in this case, leaving him with palliative care as the only regimen. At this point, the patient reported to the healthcare team that he had resigned himself to his forthcoming death, but that the team should not inform his family about the true state of his health. Mr. Banda also confided to one of the medical students that he planned to kill himself and that the student should keep his decision a secret. So that is the story. And then number one is saying identify the three main ethical principles evident in this scenario. Now we know the ethical principles. We have got four: autonomy, beneficence, non-maleficence, and also justice. Justice is about distribution of resources to cater at least for many people that have less access. In this story, we have not really gotten any problem to do with it, the distribution of resources. But autonomy is there because the patient wants to make their own decision. For example, uh, they don't want the family to know. And then beneficence is the desire to do good. So the doctors initially tried to help this patient, but then he refused himself. So that is the desire to do good. Beneficence will normally go with non-maleficence, also the not doing harm. When you are trying to do good, you are not doing harm. But of course, there are points when you are trying to do good and then you can end up causing harm. So, in whatsoever means, when you are trying to do good, make sure that the good you are doing doesn't cause harm. Number two is saying an ethical dilemma arises when a person must make a choice among mutually exclusive alternatives. So these are alternatives that are really different. Okay. And then determine two ethical dilemmas that the healthcare team and the medical student will deal with while trying to abide by the ethical principles you identified in question one. From the story, any ethical principle, any dilemmas that we have seen that have to be handled. Anyone? Dilemmas that we have identified? So for this question, as we mentioned the dilemmas, we want to mention the dilemma and the remember the dilemma has got two or more mutually exclusive alternatives. So when we mention those alternatives, it's also supposed to state which principle is uh, being fought in that case. I can start with one example. Mr. Banda here confided to one of the medical students that he planned to kill himself. So here the medical student has got an option to keep quiet to maintain the autonomy of Mr. Banda, or speak so that he does good, right? So those two. Any other dilemma that we've seen here? Anyone? I know we know. Let's speak. Okay. So besides that situation, there's another one where the patient told the health professionals not to tell the family. So again, the health professionals have got a choice not to tell the family, but if they don't tell, that might actually affect the desire to do good, because in management, the family should be really involved. And then if they tell the family, what happens is that that is going to go against the autonomy of the patient. So what we have here, we have got informing the healthcare team, and also, so this is the one that we mentioned. The patient wants to commit suicide when the what he told the medical student. So the medical student can decide to talk about the suicide, okay, or not. So what happens in that case, informing the healthcare team about the suicide plan or the family about the patient's end of life situation will violate the patient's autonomy and betray confidentiality, and also provide the opportunity for the best care. So if the information is given, there's going to be best care, that will be beneficence. And then the other one is keeping the information from the care team facility will preserve the patient's autonomy but betray the beneficence principle. So this is again another one where the patient actually mentioned. Now this is specifically from the family or the healthcare team. Remember, the patient said, "Don't tell my family about the diagnosis that you've given me." Keeping the information will be autonomy. But then, if the information is given to the family, that will be beneficence. They'll be doing good. Okay. Another one, informing or not informing the family care team may or do not harm the patient. So if you inform the family that this man has got 4 months to live, it will not harm the family, right? So, actually, not the family but the patient. It will not harm the patient. So, that is non maleficence. It will actually be it will be harmful from the patient's perspective only. So, if the patient is the one considering it, for them it will be broken trust. So, from their perspective, it is going to be harmful, and so that autonomy would have been broken. But from considering from your perspective, looking on the patient, there is no harm to the patient. So that is non-maleficence. So when we are mentioning the ethical dilemmas, we're supposed to mention the two aspects and then also state the ethical principles that are contradicting in that case. Okay. The next question is saying, one of the most important obligations in healthcare is taking positive action to promote the health and well-being of the patient. State the ethical principle that completely identifies with this obligation. So remember, taking positive action to promote the health and well-being of the patient. What ethical principle aligns with this one? Anyone that can help with that? Okay, thank you so much. So positive act. So beneficence is about the action that is going to promote health. Now, non-maleficence is about doing something that will not do harm. So here, a full mark therefore is going to be given for beneficence, because beneficence is what does good, promotes health. Non-maleficence is not doing bad. It can also promote health, but it's not a direct correlation to the statement. I'm doing good. Doing good can promote health, and that's a direct statement given here. Not doing bad will also promote health, but it is an indirect way. So the best one here is beneficence. So specifically for this one, if someone gave non-maleficence, from the 2 marks, they'll be given 1 mark. Number 4 is saying, what ethical theory highlights the medical student's duty as a health professional with responsibilities to the patient, medical profession, and society? What medical ethical principle talks about duty? Any thought on that? Thank you so much. Deontology, right? So before I can even go further, let's just mention some important things about the ethical principles. Ethical principles are just moral principles that guide judgment. Okay, medical workers are going to, so it is just guiding the judgment that medical workers will have to make. Remember, it's the medical ethics, it's not just any ethics. Now, this is important because in this judgment of the decision that will be taken is to provide the principled care for each patient and clinical situation, meaning that each patient, there is a certain way in which you are supposed to deal with them, and also for even for the same patient, but depending on the clinical situations, you have to judge differently for you to make a decision. So that is about the ethical principles. Now we have got different theories that talk about the principles in ethics. For example, utilitarianism. This one's utilitarianism, proposed by Jeremy Bentham, and then there's also this guy J.S. Mill. About utilitarianism, this is all about doing good. Okay, not really about doing good, but the end result of something. We don't care what we have done as long as the end result is good. Let me talk about something maybe that, okay, let's say you end up killing, but you get money at the end of it all, and then you start helping the poor. Or you are involved in corruption, you get money, you start helping the needy. So according to this principle, that's fine, as long as the end result is pleasing majority of the people. So this one is about the majority. Okay. And another thing about this principle, of course, is not about hating people. It is a principle, uh, it also produces the greatest amount of pleasure or lack of pain for the greatest number of people. And the thing is that you can hate some few people as long as majority of the people are happy. So this is different for your relationship. For your relationship, we all want you, but you are going to hate us so that you can be with one person. So it's the direct opposite. Don't use this principle for your relationship, please. Okay, you want to please every guy, and then you hate your guy. Oh, anyway, so another theory is the deontological theory. This one was proposed by Immanuel Kant. So this one is about duty. Okay, you have got a duty to follow or an obligation to obey set principles, right? And that's important. For example, in scripture, we have got a duty to obey. What determines right and wrong, or what determines someone who is ethically right or not, is on the obedience of duty. I've got a duty to obey the commandments of God, right? If I obey them, then I'm ethically correct according to the ontology proposed by Immanuel Kant. And do you actually know that it is the duty of me as Mwansa to provide for my girlfriend if I've got one? If I fail, then I'm not doing a good job. I need to release her so that another one can provide. Scripturally, that is it. Okay? I'm supposed to be a provider. And it is the duty of a girl not to bring our own principles or our own vision in the relationship. Hers is to come and support my vision. It's her duty. So if those two things happen, then we're going to go in a good way. So if a girl brings her own vision, I also bring my own vision, we're going to have two visions. So that is going to be division. What is that word? Division. So the relationship is going to end. All right, forget about that. So the next principle is principalism. Now, principalism, this one, it's about following the major principles of ethics: autonomy, beneficence, non-maleficence, and justice. Okay. So this one is going to just offer a balance. That is principalism, offering a balance amongst this. When you want to make a decision, you are going to see, okay, between autonomy, beneficence, which one am I going to balance here? So normally this principle actually gets to conflict. For example, if a mother refuses care, and then you're also looking at the fetus might die. So should I respect autonomy or for me to do good for the sake of the fetus? So normally the principalism theory gets to contra. I've forgotten the last way, the last part. Contra, I don't know. So the next one is the ethics of care. Now for the ethics of care, this one emphasizes relationship, empathy. All right, it's ethics. So here it's a moral theory that emphasizes the importance of relationship and empathy and the responsibility to each to care for one another, especially the vulnerable people. So according to the ethics of care, you have got a responsibility. If someone is vulnerable, you have to be empathetic so that you can help them. All right. So this one, please take note that it's about relationship and empathy, but it's less common. It's very less common taught. And then there is the Ubuntu ethics. Now there's one that I've not talked about. The Ubuntu ethics. This one is about. It's a humanistic African philosophy. It emphasizes community, compassion, and shared humanity. And it centers on the idea that a person becomes fully human through relationship. So these two guys about relationship, Ubuntu ethics and ethics of care, basically the same. Actually, Ubuntu is going to be falling also in ethics of care. And then there's the virtue ethics. What is virtue? So virtue is the moral excellency or admirable traits. For example, what comes to your mind if you think of Mwanza? I don't know what you think about, but I think there should be something good you should think about, right? Maybe you should think of, I don't know what you think about anyway. Maybe my ex he told you some things and then you think about but okay, so virtue ethics is basically about excellent admirable traits like courage, honest, compassion, integrity. This should be the things that define you. If they say that dog, oh, that one is courageous, is honesty, not that, yeah, yeah, I like scam my way. No, that's not good. Okay, so that is the virtue ethics. So about this theory, it emphasizes character, okay, and cultivating virtues. So as in other words, it doesn't matter what happens as long as my character is good. All right. So in a situation when you are using the virtue ethics, you have got a situation at hand that is supposed to solve. The question you ask yourself is not what should I do. We don't care what you should do. The question you ask yourself is what kind of person should I be in this situation? Or what is a virtuous person going to do in this situation? Not what should I do. Because I think most of the times, imagine you are in a relationship and you see someone that were crashing on before you started that relationship. And while you are talking nice things there, you are entertaining each other. So at this point, the question should be, what should I do? According to the virtual ethics, it's not that's not shouldn't be the question, what should I do? Because what you should do is your body is telling you this is a person that you've always liked, right? Try to whatever. But according to the virtual principle is what kind of person should I be? And this should be a principle we should be working with. It's a very good principle. Very beautiful one. Okay? Very nice one. I can go in scripture to tell you about it, but it's here. First Corinthians 9:24 to 27 says, but I punish my body, I beat my body and put it under control. So this is the principle. The principle of punishing your body, putting it under control, so that you can be that person of character. Okay? I think we've described it well. So some things we should know in comparison now, the ethics of so for these principles we mentioned, we have got the ethics of care. It's more about relationship and empathy. Deontology is more about duty, following rules and obligations. And this is about the Old Testament. If we come in Christianity, we no longer follow rules because the cross has given it all to us. And then utilitarianism, this is about consequences. As long as the consequence is good, I don't care. If me being with this person is good, I don't care who I am with. I'm gonna be with you for now. Even if I'm cheating on my partner, and this is the one that majority of us here we are using, right? I'm going to cheat on him because I'm enjoying now. The consequences are beautiful. And then the virtual ethics is about character. As long as my character is good, yes. And then the principalism, this one is just about application of principles. Which one am I going to follow? Is it or not autonomy? Is it maleficency and such? Okay. Now, the key, you have got key questions to ask here. Who is affected and how can I help? That's the question you ask in ethics because you are looking at empathy and relationship. Who is affected? How can I help? For deontology, what is my duty in this case? Utilitarianism here is what brings the greatest good for the greatest number. And then virtual ethics is what kind of person should I be? And then for the principalism, this one is which principle applies. So that is what you follow. Another thing, the last thing I should mention is the people that proposed these principles. So the ethics of care, this was proposed by Carol. This one, if you want, don't know it, because even the one who taught didn't mention it. But let's make sure we just take note. And then deontology is Immanuel Kant. So this bro is the one who was saying, as long as we are enjoying, it doesn't matter, right? It doesn't matter as long as we are. This guy is actually, as long as we are following duty, it doesn't matter what we are doing. That's why for we have got some religions that can kill, because for them that's duty. It doesn't matter what the effect. And then the utilitarianism, this one was proposed by Jeremy Bentham and the John Stout Mill. Please take note, this is actually one that came. So this one is also known as the consequentialism theory. Actually, utilitarianism is a component of consequences. So you basically look at consequences. And I wonder why they were making wrong utilitarianism but making correct consequentialism, because this is basically the same thing. The virtue ethics was proposed by Aristotle. And then for the principles, that one shouldn't know. At least take note of the Immanuel Kant, the Jeremy Bentham, and also the Aristotle. Okay, so back to this one. So the question was, what ethical principle highlights the medical student's duty? So because it's duty, that is deontology. And then the next question is, the medical student considered disclosing Mr. Banda's intended suicide to the seniors. What level of communication does this highlight? Because so communication, because they are communicating to the next person, right? So that is the interpersonal level. Okay. Oh, actually, this one, the medical student is They didn't say it, they just considered. And this is where it can become a bit tricky. They only considered, meaning that they were thinking within themselves, maybe I should tell my seniors. So that is intrapersonal. If they actually told the seniors, that would be interpersonal. Okay. And then number six, the theory that emphasizes developing appropriate professional characters such as truth telling is dash. However, its major limitation or challenge is dash. So, of all these theories that you've talked about, when you look at the virtual ethics, this one that tells us about the character, it tells us it doesn't matter what you are saying as long as it's a lie, even if it's saving someone, it is wrong. I'm concentrating on this so that we shouldn't cheat you people. We shouldn't be cheating on our friends. Okay? You went and started talking to a girl. Your partner asks you, where were you? Because you want to protect them. No, I was actually studying. No, that's wrong. According to the virtual ethics, that is wrong. It doesn't matter if you are protecting someone. Okay, maybe it can be even your family member. Okay. Where were you? No, I was studying because you don't just want. Do you have some money? Because I saw you giving a 50 kwacha to your brother. No, I don't have money, but you have a 20 kwacha because you're afraid of giving it. So please say the truth, okay, according to the virtual ethics. Now, the problem with the virtual ethics, it is very much emphasizes truth, but the problem with it is that it is not good for decision making. That's a problem. I will mention all the challenges that each one of these theories have. But take note for the virtual ethics, it is less structured for decision making. Okay. Most of the times, that's why you lie, because for the virtual ethics, it's less structured for decision making. So just remember that. Why do I love lying? Oh, because my character is bad. I'm not vicious. Okay, number seven. Okay, someone has a question. Please, that question we can go on. Yes, Doc. Okay. So this one, the medical student considered disclosing. So intrapersonal level of communication is where you are just thinking within yourself, contemplating or meditating. You have not brought it out to anyone. So the thought is just within. So here, the medical student was just thinking within themselves. They considered disclosing, but they didn't disclose. So that is intrapersonal. All right. So number seven is saying the principle of autonomy is more oriented towards individualism, allowing Mr. Banda to make his own decisions, even if it does not align with the family's wishes. Hence, his plan to keep his family unaware of his prognosis. However, this is actually just dash and ethical theories encourage relational care built on communal support. So, which other theory besides the ethical one is talks about relational care? Like we should relate more when we are making a decision. You should consider also others and not just yourself. So remember all the theories we talked about. We have got the ethical, deontology, utilitarianism. You have got Ubuntu. You have got the virtual. So which one? Here we've already been given the ethical. Which other one tells us that before make a decision, actually consider the relationships that you have? Anyone? So remember the one that is talking about The Ubuntu. Ubuntu is also about relationship. We said it is a sense of community, right? When you're making decisions, always think about the general, a lot of people. So the ethical and Ubuntu, though Ubuntu is actually also inside the ethical, but put it also like that. Now, this question they had said, however, dash and ethical. So they had already given one. So those are the two you mentioned. So when it comes to the principles that we have mentioned, like deontology is mostly based on duty, right? The strength of deontology is that there's going to be clear moral rules and it supports the code of conduct. Like you have got already something you should follow. So the really conflicts are going to be little because you already have something you are going to follow. But this rule can actually be really rigid in complex cases where you don't need to follow a rule. Okay, because it's not every time that you're going to be following rules. Sometimes you have to make a decision out of the rules. So that's a problem with deontology. But this one is going to align with professional codes in Zambia. And then for utilitarianism, this one you do the greatest good for the majority of the people, and it is useful in resource allocation. Let's say, for example, you want to help a class with some materials. Let's say at Ridgeway campus, they made 4 class is the biggest class at Ridgeway. So when you want to help the majority of the people, so you help them, right? So that is the strength. When you are allocating resources, give the majority. But then the limitation and the challenge for this one is that it may neglect the minority, and that's a problem. People that the minority might continue suffering and suffering, and this is what has been happening, isn't it, at Ridgeway campus when it comes to the Unzasu elections? Because the majority are the medical students, always the entire executive is always coming from there. So there has been this neglect of the minority. So this time around, we are also going to be neglected. So let's make sure we clear, because there's no one who will go and stand and face these people in those offices. Okay. And then for the virtue ethics, this one will focus on moral character and virtues. The importance of this one is that if it emphasizes empathy and integrity, basically good standards. And then the limitation is that it is less structured for decision making. Okay. And it resonates with Ubuntu value of compassion and humanity. For the principalism, this one basically follows the principles. The strength is that it is widely used in clinical ethics, but then the limitation is that it may oversimplify uh, ethical tension. It might just oversimplify it. No, we are just going to follow A or B. Okay, let's follow autonomy. Okay, let's follow beneficence. But there's more to making ethical decisions than just following those 4 principles. And then the ethics of care, this one emphasizes the relationship and empathy. And the strength is that it supports patient centered care, because you are talking about a relationship and empathy. You'll be looking at the patient. So it will support the patient centered care. But then it is less formalized, and then it is only context dependent. For the Ubuntu, I am, we are. So this one focuses on relational ethics. That's the Ubuntu. And the advantage is that it promotes solidarity, working together, and mutual respect. The disadvantage or the limitation is that it may conflict with Western individualism, because when it comes to the Western culture, if we did history, there's a guy who was called Otto von Bismarck, who said, each man for himself and God for us all. So these guys, they want to be in their own world. But then you are talking about a sense of Ubuntu where there is a relation, so it might actually conflict in that case. Number 8 is saying identify one major interpersonal barrier evident in the case scenario. Oh, this one is actually intra, not inter, but intrapersonal barrier. evident in the case scenario. Any thought on this one? Any intrapersonal barrier that you've seen from the case scenario? So when we are talking about barriers, we have got external or physical barriers. This is basically the environment. For example, noisy, weather, no privacy. There is also semantic barriers. This has to do with language. For example, you using jargon, slangs, acronyms, and then there's also cultural differences, and then also there is time constraints. There is interpersonal. Interpersonal includes, for example, when you are discussing with people where you are of different hierarchies, power dynamics will disturb the communication, or even lack of trust. Mhm. It comes back again. Sorry for using it again. So you cheat, short. You cheated once, they caught you. The next time they find you talking to a person, even if you are just talking about scriptures, they'll refuse. No, me, I'm a man of God. I talk to many people. They will not accept that you're a man of God because the trust has been broken, right? So, and also things like conflict. For intrapersonal, this one has to do with things like assumptions. You're just making assumptions that will disturb communication, jumping to conclusions, attitude, perception, the way you just perceive situations, expectations. I just say no. I think you are hungry. You're already thinking that I'll give you money. No, don't think like that. I'll not. And then emotional states, low self esteem, mental distractions, for example, internal thoughts. So, all these can be intrapersonal barriers. You also have physiological barriers, like, for example, hearing difficulties. If there is data overload as you are getting to listen, that can actually disturb communication. Okay, even organizational barriers, but organizational barriers can actually get to fall in the interpersonal. For example, hierarchy, poor communication channels, lack of feedback mechanisms. So here emotions were present, even an emotion like, for example, attitude, the attitude that was being displayed by the client towards the health professionals, that would have affected communication. Number 9 is saying you are the medical student whom Mr. Banda confided in about his intention to commit suicide. You inform Mr. Banda that if he agrees to tell his family the truth about his condition, you will keep his secret about his suicide intent. This is because you feel that the family will always be around him if they know his health condition, hindering his suicide plan. So the external factor affecting voluntariness exhibited here is, so Mr. Banda has told you that I want to kill myself. And then you start telling him, no, actually, okay, tell your family that you are sick. Because he also was refusing to tell his family that he was sick. And then he also was planning to commit suicide. So he tells you he wants to commit suicide. And then you're telling me, okay, I'm not going to tell your family that you want to commit suicide, but tell them that you are sick. So in this case, what external factor was affecting the voluntariness uh, for Mr. Banda to tell his family? Any thought? Okay. So whatsoever voluntariness they are talking about, the external factor affecting voluntariness exhibited here is, so here what is happening, the external factor actually what is happening for the student is telling Mr. Banda that I'll not do this, but for me not to do this one, do this for me. He was actually manipulating the patient. So there is external factor there, which is manipulation, so that Mr. Banda can make a decision in fear of one thing. What will you do as a medical student if Mr. Banda agrees to inform his family? Any thought? Mr. Banda agrees to inform his family. What are you going to do in this case? Because also the doctors don't know that Mr. Banda wants to commit suicide. Any thought on this one? Remember, for you as a medical student, you can't go and start telling the family, no, actually, your sibling or your father wants to commit suicide. But what we can do as medical students is to tell our bosses, our seniors, and then our seniors will be able to take it up from there. So inform the seniors, the team leader, the consultant, or whoever is leading us at that particular time. Number 11 is saying if Mr. Banda's refusal to inform his family about his condition is gender based, using constructive perspective, explain briefly explain why he does not want his family to know. Now, Mr. Banda's refusal to tell his family is remember is gender based. So according to these gender issues, for a man, if you are going through situations, it is actually strength if you don't tell anyone. That's why men, let's be good to our fellow men. And ladies, if you're in a relationship with a person, try to listen to that person. Give them some time. I know, ladies, we want to talk nearly every second, right? We don't want to listen. But try to listen to these guys, okay? If you are in a relationship with them. Not every time, no, I need bundles. Every time I want Brazilian. Eh, someone is thinking about committing suicide, and then there's another Brazilian coming in. It is just another stimulus to commit suicide. Okay, so, all right. So, in that case, so Mr. Banda, because he's using the gender based principle, he feels not telling the family is actually being strong and is trying to protect the weak ones in the family. And actually, him not telling the family is being strong, is not showing his weakness. And I can tell you this is so real. If you just open my heart, just peep there and see how many things are hidden. Okay. Number 12 is saying many argue that confidentiality is not absolute. Identify only two conditions that make it legally permissible for the medical student or healthcare team to breach the oath of confidentiality to Mr. Banda. What situations can make us not to be confidential, to breach confidentiality? Any thought? Hmm? Imagine you are dealing with a patient who wants to kill themselves, and then because of confidentiality, they've even told you they want to kill themselves. You let them. They'll commit suicide, and just imagine the kind of guilt that you are going to suffer with for the rest of your many years under the sun. So if there's risk of harm, okay, to himself, if the person wants to harm themselves, you can breach confidentiality. And also, if you sharing the information will actually result in better management of the patient, confidentiality can be breached. And then if the patient has got mental, emotional disorders, but how do you know the emotional ones? If they're in a heartbreak, don't trust people in heartbreaks. They don't make proper decisions. Okay, so for those, if you know, you've known me, and then I was in heartbreak, and then I'm telling you things, and then I said, don't tell my family. Please go and tell them because you know that I'm in heartbreak, and I can't make a decision that is sound. Okay, so please put your trust in the Lord. And then also, if the information, revealing the information is going to be important for research, you can actually review the information. You can break confidentiality. Number 13 is saying if informing the family about Mr. Banda's decision to take his life results in good, the ethical theory it represents is dash, with dash as its many proponent. Okay, so results in good. What theory talks about good? As long as it's good, the result is good, then we are good. And who proposed it? Any thought? Mhm. So when we are doing good, remember good is about consequences, right? As long as the consequence is good. So this is the utilitarianism, also known as the consequentialism. But in the notes that the madam gave, there was no consequentialism. There was actually utilitarianism. So this is still making me wonder why they were marking wrong utilitarianism. But it's actually just a subtype of consequentialism proposed by John Stuart Mill or J.S. Mill. I think if you said J.S. Mill, they can't mark wrong. Huh? John S. Mill. Okay. Number 14 is saying, imagine some of Mr. Banda's test results got misplaced or were missing. List two possible problems that could arise from the misplaced or poor documentation. Now, this is a problem misplacing results or poor documentation. Imagine you misplace results of someone that has got a terminal illness. What is going to happen? They're going to die. And if the family finds out that they died because the results were misplaced, what do you think is going to happen? Legal action is going to be taken against you. You'll be sued. And then what happens? The license is going to be revoked. And then you are going to go back to carpentry and binding. So, yeah. So if there is misplaced results or poor documentation, it can actually get to result in gaps in care. There will be conflicting care, and then those are problems. They can actually be also a waste of resources because if there's misplaced results or poor documentation, you might just actually repeat the same thing that you did, the same procedures that you did if you lost the results, and that will waste resources. There also be poor quality coding. You are not taking record of the results. The rejected or denied claims from insurance outfits. Imagine someone says, no, I'm actually very sick and I need you to help me. From the insurance, you go to an insurance company. They are going to ask for these documents. Okay, let us see the condition that you have. And then imagine the results have been misplaced. So that might lead to denial or rejection of the claims from these insurance outfits. And then they can as well be delayed or inappropriate clinical decisions. The results are not there. And we've been seeing this many times if you are in the hospital, isn't it? Okay, let's do again the result. Where are the results? No, they are not here. Okay, let's do the scan again. And imagine you want to make a decision for surgery and then you're always losing the results. Another problem is that they can actually be compromised continuity of care. Let's say I'm the doctor that is handling this patient and then I lose the results or I misplace them. And then I leave the facility. Another doctor starts handling this case. The doctor might not be able to continue the care of that patient properly. It can compromise the continuity because they are again going to start from the beginning, right? Again, poor documentation can expose the team to medical legal consequences. I already mentioned that one. Inaccurate prognosis communication. You lose the results. You might not know the prognosis of this case. Maybe someone that is going to die soon, and then you are still asking for more results again. So it can lead to inaccurate prognosis communication, and then obstruction of palliative planning. Some people there's no treatment, so if the results are there, maybe the only thing that requires is palliation. Okay, the only thing we're going to be doing is supporting you. There's nothing we can do in this state. But if the results are not there, it might actually delay this palliative care and it can result in the death of the patient. There will also be loss of trust. All right. Why would a healthcare professional consider Mr. Banda a difficult patient? So in this case, remember Mr. Banda was actually initially Mr. Banda refused treatment, went for 5 years. So they rejected treatment, and that is actually a problem. So we'll consider them to be non-compliant. And also they were refusing for the information to be given to the family. So it does not share information to the family, okay, as it should. And that can actually alter management. Number 16 is saying in the 9 steps approach to end of life communication, what many environmental factors will you consider as a healthcare professional when arranging a meeting with a patient? So in the 9 steps, as you arrange a meeting with the patient, imagine you want to deliver bad news. Okay, you are going to die very soon. You have got 6 months, and then you're in public. Okay, you die. You've had. No, you don't do that. Sit properly with the patient, where it is quiet, where it is private. Okay, away from disturbances. So make sure that the environment is well prepared. So those are things to consider. So the environment should be quiet, conducive, no interruptions. Right. So in these steps, when it comes to e- end of life discussion, you prepare for the discussion. What do you do in that case when you're preparing for the discussion? You are going to ensure an appropriate private setting, adequate time, the environment is good, and then you assess the perception of the patient. What does the patient understand about their condition? Okay, and then ask for an invitation to disclosure of information. You should ask the patient, should I tell you the details about your condition? If they don't want, they are not ready, don't tell them. And then elicit and respond to preferences. So here again, you ask about a patient's values, priorities, and what is most important to them in the time that they're remaining with, because they have allowed you to talk to them. So ask, what do you prefer to do in this time? What is important for you? Okay, maybe maximizing the time with family, avoiding hospital. Maybe they say they don't want to be in the hospital. Yeah, you know there's nothing to do for them at this point, so you can allow them home. And then sharing prognostic information. Okay, this is the information. Be honest, even if it's gonna pain, but know how to deliver bad news in this case, right? Should be able to know how to deliver. Remember, we talked about these models like Kekon's model when, of course, the emotions are really high in this case, and you want to hide some things from the patient, but that is actually not right. Even if you are feeling emotional for whatsoever reason, you're supposed to still tell the patient the truth. Okay. So that is going to be so important in that case. And then after that, ask if the patient has got questions after you tell them about their problem and such, and then check for agreement with the plan. So you are going to summarize now everything, and then does the patient agree with what you've planned as a medical professional, right? And then after that, affirm the patient's decision, support them. Okay, support them, because this is going to be, remember, it's you are making an end of life decision. So you got to support them, give them time to express themselves. And then lastly, also ask them what they really do, if they would maybe need some support, spiritual support, emotional support, or such. So for someone that is emotional, and you are talking to the patient in end of life care, right? You are talking to the patient. In this state, you also might become emotional. So the model that you can use in that case to deal with to manage your emotion is known as the Cohn's model. C is the context, O is the opening shot, N is the narrative approach, and then E is the emotional address. So you are going uh, to address the emotions with empathy. But in case you made a mistake with a procedure and then you are telling the patient, okay, I made a mistake, or maybe you are telling the family about the mistake you made, you use the Buster model. B is for be prepared. U is use non-judgmental listening. S is the 6 second rule. When you talk to the patient, pause. Okay, pause before responding to allow emotions to pass. Because remember, you made a mistake and then you are telling the patient that you made a mistake. So they might be actually very upset. So if they say something, pause before you can respond. That's a 6 second rule. And then in the buster, the T is the tell me more statement. So allow the patient to tell you more, and then is empathy, empathize with the patient, and then the R is now you responding with a wish statement. I wish I had better news. I wish it didn't go like this, but well, I gave you a wrong medication. Okay. Number 17, the WMA ethical code will enable the medical care team to respect Mr. Banda's autonomy, confidentiality, and professional integrity. The main area of difference between the ZMA framework and the WMA code in providing care for Mr. Banda is, so we've actually been told that WMA ethical code will enable the medical care team to respect Mr. Banda's autonomy, confidentiality, and professional integrity. So now what's the difference between WMA and ZMA? So when you look at this, the W there, WMA is just representing World Medical Association. And then the ZMA, that is the Zambia Medical Association. So the Zambia is, this one is talking about the local context. So this one, ZMA is a local context, and then the WMA is a global context. So what's the difference between the framework? The main area of difference between the ZMA framework and the WMA code for providing care. So the difference is that one is local. We use our local principles here, and then the WMA is international. So it's actually not everything that is in the international statutory instruments that we follow locally. So there might be these contradictions. Okay. Number 18 is saying, on what ground could the medical team judge Mr. Banda incompetent to make an ethical decision? So I already mentioned this. If they've got mental incapacity, emotional incapacity, it's on that ground that you can actually even breach confidentiality because the patient can't make a decision. Okay, so if they've got mental or emotional grounds based on the illness. Number 19 is saying the success of a medical interview depends mainly on the physician's communication skills. Mr. Banda communicated his intent to a medical student, not the doctor. Any sentence suggests why he did so. Now, what could be the reason? Okay, let me, before we even mention this, what's the reason why you, my brother, you find it more interesting to talk to Abigail, who is not your partner? You actually talk to Abigail for 3 hours on a phone call, but your partner, 2 minutes when you are talking, you already run out of talks. Why? Or maybe you're my sister. Why is it that you find it so hard to talk to your man? 2 minutes, you are already tired of talking. And then when you start talking to this bro, Mwanza, or this bro, Josephat, you can talk for 3 hours. You're even saying, let's take a walk. What's wrong with you? How do you want to take a walk with him? Take a walk with your partner. So, that person you want to take a walk with, that's supposed to be your partner. And no, I just feel nice talking to you. The stories just go properly. We relate. That's supposed to be your partner. So dump that one. Start a relationship with that one you're talking to. Why are you causing problems in society? So there's actually no rapport between you and your partner. So if there's no rapport between you and your partner, that relationship is a waste of time. Okay? So the doctors are not being told. That's because they don't know, they can't make a relationship with Mr. Banda, right? They can't make that rapport. They can't gain his trust. You know, one thing, let me tell you a secret, you people. When you gain the trust of people, people are not hard actually. I remember when I was a child, there is this person I used to talk to every second. We used to argue. For 1 year, we used to argue. And then when we created the rapport, we now started talking for you're talking from 22 hours to 05. What's happening to me? You see, when you create a report, so create a report. Create a report, guys. Yeah, anyone is interesting to talk to as long as you create a report. Okay, so number 20 is saying use a diagram to, by the way, that's just a story. I don't talk to people from 22 to, I'm a single man. Use a diagram to illustrate the communication process evident in the scenario. So in this scenario, expecting that this is actually a one-to-one communication, right? And we know that for one-on-one communication, When we are using a diagram, we already know the arrows that we use for one-on-one. So we have got person one, that is going to be listening, and then person two is going to be getting the information. So that model is known as the linear model. Because in this scenario, actually, the doctor is going to be talking to the patient, and then the patient also is going to be talking to the. No, normally, in a scenario like this, the doctor is going to be presenting the information. That's why there's no report, because the doctor is just coming and giving the information to Mr. Banda. So that is a linear model. And what happens in the linear model? You have got communicator one, and this communicator one, or who is now the sender, is just taking the information to the other person, and then the other person is just receiving it. Okay, so I've got one going to two, and this is not a good way of communicating. You also have the interactive model. Now this one is a two-way communication, the interactive, where I've got a sender and the receiver. So the sender will send information to the receiver. So the sender is going to encode, and then the receiver is going to decode, receiving that information. And then the receiver, once they receive the information, they can actually send the information back. That is the interactive model. And this one is the one that we use. Let's say if you're on a phone conversation, when you're text messaging, when you're emailing, right? Sender, someone first has to listen to what you're trying to say. So there should be active listening for the interactive model to work. And then the last one is the transactional model, which is the best. In the transaction model, this is simultaneous communication. Okay, you say something, sometimes even before someone finishes saying, you also come in. Actually, let me say, and that is why you find that you are feeling nice to talk to that person, because they know me. Don't allow me to talk to your partner, my dear friends, okay? Because me, I use the transaction model. I know how to talk, so they'll just be feeling nice, and then they'll leave you when I'm lying. Okay, so you have got communicator one, and then you have got communicator two. There's communication. This one that has been displayed here is actually the interactive model. This is the one that was being displayed in this case. So you are able to talk to the patient listens, and then once they talk to you, they listen to what you are saying. They also say, actually, doctor, I also think this. So you also receive the information. But as the communication is happening, there is actually noise here. This noise is what we call communication barrier, right? So that is what happens. And then 21 is saying, you presented a talk on Mr. Banda's hypoproteinemia to the medical team, but were unable to respond to some of the questions from the audience. This is because, you know, they they have said it's lack of preparation. So you've prepared a talk, okay? You presented a talk. Actually, you presented the talk on Mr. Banda's case to the medical team. It's like a major word round, right? It's a major word round. You're going with the doctors, and then you're saying, no, actually, you collect the case. Actually, Dr. Band, Mr. Banda has got hypoproteinuria from the lab results. Yes, doc, tell us what caused hypoproteinuria in this case. What do you think? It's not lack of preparation, actually. There's no data. You didn't read. Anyway, no data is lack of preparation, right? Yeah. So that is what is there. There's lack of preparation. There's no data. So in the reference list for the presentation, you use the journal article. Which part of the journal article did you italize? Now, when you are looking at the reference, what you italize is actually the name or the title of the journal. Okay, so depending with what you are dealing with, say for example, if we are dealing with a book, you want to use the Harvard referencing style. For a book, we are going to use the author's surname first and then the initials. Okay, for example, PRP, and then you put the year in bracket in parentheses, which the book was released 2002, and then you put the title of the book. The title should be italicized. If you don't italize it, make sure that it is underlined. and then now you are going to put the place of publication and then the publisher. That is for a book. If it says journal article, you are going to put the author's name, surname first, and then the initials, and then you put now the year in brackets, just like we can see here, and then again the title of the article. And this is the tricky thing, okay, because this question was saying you used a journal article. Which part are you going to italize? Because for an article, you have got the title of the article and the title of the journal. You don't italize the title of the article, but only the title of the journal. All right. So that is important there. Okay. You are going to italize the journal title or the journal name. So please take note. You are going to put the title of the article like here, but here I even underline majority of everything because I didn't use the italics. But please, you don't do that. This is an article. You are going to put the title of the article just like that, and then the title now of the journal, that's the one that you are going to italize. If you don't italize, it's the one you underline. So this other part here wasn't supposed to be underlined. And then the next thing is we're going to put now the volume. So this is volume 2, and then the issue number. The issue should be in brackets, that's 2. And then you put now the page number. Please don't forget volume, issue in brackets, and then page number. The page you are using PP, and then you put the page. For a website, you put the author, organization, and then the year of publication, and then the title of the page. Because remember, this is a website. So what is the title of the page? Okay, let's say uh, substance abuse. And then now you're going to put the available URL www dash 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 dot. Okay. And then I think that's that. Yeah, that's that. Okay. And then the next question 23 is saying you use the chronological pattern during the presentation. What happens in the chronological pattern? Chronology is about order, right? Starting from what starts first to what comes next. So information is arranged according to the pattern of time, starting with what occurred first and then what occurred later. That is chronological order. So that was question 1. Question 2 was about definitions. So from the options provided, choose the correct terms for the definition. We have got explicit consent, disclosure, autonomy, implicit. We have got external, this is supposed to be external barrier, together, one word. And then capacity, force, semantic, this is also supposed to be semantic barrier, one word. And this is supposed to be intrapersonal barrier, one word. And then competence. Okay, so the next question is saying consent indicated by patient's behavior is referred to. So patient's behavior, this is implicit consent. Like they've not really said that do it. The explicit consent is where they actually tell you they agree. Now, just you seeing, okay, I think this one is agreeing, just by from the behavior. And this is how majority of us ended up in relationships. Why am I talking about relationships today? There are times that you miss being in a relationship. Huh? Maybe I'm missing. So yeah, you some of you guys consented implicitly. She just said, and then you said, "Oh, she loves me." You started buying shawarma, and then you discovered she actually doesn't love you. Oh, bro. Number 2 is saying the process during which a patient is provided with information on a proposed medical intervention and allowed to make own decision is called. So you tell them, okay, you them proposed, and then you allow them to make their own decision. What is that called? That process that is known as disclosure. So disclosure is you telling them, okay, but now they have to also make their own decision later on. So that will be now the concept coming in. All right. And then 3 is saying the ability of a patient to understand information provided by the clinician and take responsibility for their decision. So they are understanding information provided and then take responsibility. That is known as the capacity or competence. They are competent because, let's say, for example, if someone is mentally unstable or emotionally unstable because of an illness, these guys, we say they don't have capacity. They are incapacitated. They can't make a decision. Because why? They can't understand anything, right? You'll be explaining the thing, but then they can't understand. They are mentally disturbed. And then the use of physical restraints or sedation to enable treatment. Oh, this is force. Okay, we are going to do it. We are going to inject you. You even hold the hands. But this is someone that can make a decision. So that is force, the use of force. Barriers that arise from visible and tangible. Immediately you hear tangible or visible, even before finishing the statement, put it there. But mind, you should be finishing statements. It's a challenge. Maybe they didn't want you to say the word. Maybe they had left a space in front dash for you to conclude. So barriers that arise from visible and tangible incidents like the layout of a room or from interference or distraction that cause one to miss part of the message is, so that is external barrier. So that was question two. Now question three is about true or false, and I've already put the options there, the true false. So number one is saying communication breakdown is an ethical issue only when harm occurs. Now this statement is false. Communication breakdown is an ethical issue only when harm occurs. Well, ethical issues are ethical issues even when there is no harm. Okay. For example, you come and do something to me uh, that is meant to, of course it's good, right? There's beneficence there, but then I didn't consent, or else I tell my family that I've got a certain medical condition for the sake of good, but then I didn't say you should say, or I refused. So you've broken the autonomy, but then there's beneficence. So that is still an ethical issue even if uh, harm is not done. So this statement is false. It's not only when harm is done, even when harm is not there. Number two is saying a doctor breaches confidentiality in consequentialism when a patient with contagious disease refuses to inform more close contacts. Now, this is not true. You know, a contagious disease is not one of those diseases that you are going to be hiding, okay? Because it's contagious. Remember, there are situations where you can actually uh, breach confidentiality. So here, saying a doctor breaches confidentiality in consequentialism when a patient with contagious disease refuses to inform close contacts. This one, you don't break confidentiality. If you tell them, because it's a contagious disease, it puts many people at risk of being sick. So if you do it, you've not broken any confidentiality there. It's actually fine because it's actually going to affect a lot of people. Or even just because it's a contagious disease, you definitely they will be informed. Even if they are not informed, just by looking at you being isolated, they will know that something is wrong. Why is this person being isolated? It's a contagious disease. Three is saying fidelity is violated patient when patient information is shared without consent. Now this is true, right? If you share information without consent, you defy fidelity. Any AHQ code emphasizes, says National Association, I've forgotten the HQ there. So the NAHQ code emphasizes ethical behavior during the global health emergency. Okay, let me try and remember this NH. So the NAH is the National Association for Health Quality. Now this one, yes, the National Association for Health Quality uh, codes of ethics and conduct. This one emphasizes ethical behavior, integrity, accountability, and the protection of vulnerable stakeholders, specifically the health recipients in all professional circumstances. But the code itself contains a separate section titled Global Health Emergency. Its core principle. I'm just reading one. I don't know what I'm reading. So on this one, I've put dashes here because when you look at this National Association of Health Quality Code, it really does emphasize ethical behavior. It will tell us as you come as stakeholders come at a global level to discuss different things. Okay, they should have ethical. There's an ethical behavior that they should all put on. So that is for the National Association of Health Quality Code. It does emphasize the ethical behavior during global health emergencies. Now, I'm just trying to wonder why they had said false. That is why I've put 3 stars there, because from my reading, this statement is actually true, according to the National Association of Health Code. The ZMA code aligns fully with the WHO code without variation, and this is false. The Zambia Medical Association does not align with everything from the World Health Organization. There are some things that actually are not agreeing. That's why in management we use actually our local rules, and then there are just some points where if the local ones feel that you go now to the international, but even as you are dealing with the local, most of the local rules actually also don't really divert so much from the international codes. Number 6 is saying justice is mostly violated when a medical student shares patient information on WhatsApp. Justice is mostly violated when a medical student shares patient information on WhatsApp. So this is false. So it's not actually justice that has been violated here, right? It's another principle. This has to do with the patient confidentiality, not really justice. Justice is about sharing resources to make sure that at least majority of the people get that. Number 7 is saying veracity guides fair decision making in resource allocation dilemmas. Now, this is not true. What guides a fair decision making in resource allocation dilemmas is not really okay. These are the things that we had mentioned. See, I think I had put it somewhere. One of those theories that we had mentioned, we had said that some theories actually are good, or let's say just when you are using justice, justice for these theories, ethical theories, is what helps us in getting to allocate resources properly and not the veracity. The question should be, what is veracity? So this veracity is just a quality of being truthful, honest, and accurate. Yeah. So being truthful, honest, accurate. And this principle in health ethics is going to be used when you are trying to to get consent from the patient. That's one example in which you can use them, because in that case you need to provide all the information to the patient so that you can make that decision. When it comes to resource allocation, that is justice, right? Number 8 is saying Zambia Health Professions Act allows disciplinary review for digital misconduct. This one, yes, the Zambia Health Professions Act will allow disciplinary review for digital misconduct. So you don't use social media anyhow in medicine. Let's say you just start googling the medicines you should give the patient. You just go, they just tell you a symptom. You go Google, you know, and everything like that. So the Zambia Health Profession Act allows for disciplinary review for such. And then the WMA code encourages full adherence to regional cultural practices without exception. Now, this is not true. The WMA, the World Medical Association Code, does not really fully encourage regional cultural practices. It doesn't. And yeah, there's actually some variation. There's actually contra. And when you think of contraindication, there's a word I want to use. Contradictions. Yeah, there are contradictions with the local or regional cultural practices when it comes to this one. That is the World Medical Association. 10 is saying the ZMA code discourages collaboration with traditional healers. False. The ZMA code actually in management encourages that you should collaborate with traditional healers, because actually majority of the patients go to traditional healers, they go to papas and such. So collaborate with them if you want to provide proper medical delivery. The main advantage of Zambia's smart care system is its ability to prevent hospital overcrowding. Now, this is not true. If you come in the hospital, you see like doctors can actually press on their phone to check the details of the patient. Now, that actually does not reduce overcrowding in the hospital, but it actually just helps in tracking information of the patient quickly. Okay, for example, you want to get the information, the lab results of the patient quickly. You want to do this quickly about just to track the patient's uh, the point at which the patient is in management. So that's what it helps in. Lack of interest in technology is a common challenge in internet value. This is false. There's a lot of there's no it's not like there's lack of interest in technology. Okay. There is a lot of interest in technology. It's actually even becoming a problem. And then number 13 is saying academic neglect, pay sleep disruption is a risk medical students. Okay, academic neglect per sleep disruption is a risky medical students in Zambia face due to excessive internet use. Now, this one I've also put stats because from the marking key they've put false, but excessive internet use actually leads to a lot of sleep and academic neglect, and this is what increases uh, failure rates. So the reason they put false here, I still don't know. For me, I can go with true. Academic neglect per sleep disruption is a risk medical students in Zambia face due to excessive internet use. Number 14 is saying curriculum redesign to promote offline collaboration is not a useful intervention to reduce medical students' internet addiction. Now, this statement is false. Yeah, because curriculum redesign to promote offline collaboration is actually useful in reducing medical student internet addiction. And this is why I don't agree with 13 being false, because the curriculum redesigned to promote this offline, because the challenge is that most students are actually using internet and they have become addicted, and so they can't study, they are losing sleep, and that is causing failure. So promoting curriculum redesigns that promote offline collaboration is actually going to be useful in reducing the medical students internet use. 15 is saying collusion is when a student hires others to complete academic work on their behalf. Now, this is not true. This is false. Okay. I'll talk about collusion, what it is, and also hiring someone to do your work, to complete your work. What is that called? But this is not true. Low context culture conveys meaning through an explicit verbal code. This is true. Low context cultures uh, includes the places. Okay, low context culture, these are places or cultures where they believe in basically being clear. When you are speaking, don't make an assumption that someone understands what you are saying. For example, places like the United States, USA, it's a low context culture. For them, they believe in explicit verbal code. If you are saying something, be clear. Don't leave me hanging. You just say, I feel nice talking to you. And then you want me to start interpreting what you mean. Or maybe simply because we talk a lot, I should start assuming that we're in a relationship. No, be clear. But high context cultures, for example, Zambia, here we use most of the implicit verbal code, where you want people to now make conclusions from what what you are doing. I should make a conclusion, or I should deduce that this is what you're trying to communicate. All right. 17 is saying information sharing and receiving co-occurs in the linear communication model. Now, this is false. Communication sharing and receiving co-occurs in the transactional model, not in the linear model. Okay, so for these misconducts in academics and research, we have got many of them. For example, plagiarism. Plagiarism is presenting someone's idea, even words, data, images, or work, okay, without their proper attribution or without citing them. And then there is this self-plagiarism, where you write, let's say, an essay today, you submit, they mark it, and then next time they give you the same question, you write the same essay, submit. That is again plagiarism, also known as duplicate submission. So that is self-plagiarism. There's also fabrication. This is where there is inventing or creating false data, research results, entries, or bibliographies, or other information and recording or reporting them as legitimate. So that is fabrication. You are just creating wrong things. There's falsification, which is manipulating research material, equipment, processes, or changing selectively omitting data or results to present a skewed or desired outcome that is not an accurate representation of the research. That is falsification. You've done a research and then you skew the data. Okay, you change the data. Let's say, for example, they say how many people in Lusaka actually are living with HIV. You find the values, they are really too much, and then you want to protect yourself or something, you change them a bit. So that is the falsification. Collusion is an authorized collaboration with someone in an assignment, or maybe an OSCE, or in a test. You are collaborating. No, actually, we are just comparing answers. Why do you want to start comparing answers in the exam? Right? Please don't compare answers in the exam. Right? And then there is just contract cheating, where you hire someone or pay someone else to do something on your behalf. Impersonation is having another person take an exam or complete an assignment on someone else's place. So that is not good at all. And then there is sabotage, which is intentionally interfering or destroying another person's work. Let's say, for example, you come home, you are my roommate, you find I've eaten your food. You go and get my assignment, you tear it because you're upset. No, don't do that. So that's that. And then other crimes include unauthorized use of AI. Yeah. So this is it for this clinical skills paper. That's where it ends.